let's look at the bronchogram, frontal and lateral chest bronchogram, which of course is a dinosaur exam today, but this is a bilateral, at least lower, low bronchogram, even though the trachea has got contrast. Notice that it's just coating. That's all a bronchogram was a mist that coated the internal wall of the bronchi. It's not filling them up with contrast. That would drown the individual. It just coats the internal aspect. And you can see the difference here and here. This is lower lobe, probably a bit of lingula, because this looks like it's into the lingula, but really more so in the basal segments. You can see how large these are compared to here. And we've got contrast all the way out into the periphery, and we really don't here. And remember what we said about bronchiectasis. That bronchiectasis is the result of something else happening. You know, something caused the bronchiectasis. Whether it's something they've had persistently, or whether it's, you know, they have that genetic one we talked about, cartageners, motile, or dyskinetic cilia syndrome. Something happened to cause the bronchiectasis. But that's permanent, irreversible enlargement due to destruction of the elastic tissue in the bronchi. And then they tend to be the big problem. I mean, it's not so much that they have that dilatation, it's the recurrent infection that they tend to have. Which is recurrent, repetitive infections, up and down. They tend to go through this cyclical pattern of feeling okay, and then they get sick again. Feel okay, get sick again. We said in class, remember, that it tends to be predominantly 4, 5, and 7 through 10, mostly. Can be the others, but it has a much greater chance of being in the basals. This is much better filling of the bronchi than what we're getting over here. They just aren't filling very well. They're too big, and we're not getting very good peripheral filling. But so imagine if we did a CT on this with air. These bronchi are too big, too far out in the lung on the CT images. When we look at the axial slices, you know, you should get tapering of the bronchi just like we do here. They should get smaller and more in number, and even on a CT, they're too big, too far out. That's how they make the diagnosis today. Bronchiectasis. Okay? Now, this is a good example. In fact, it's the one that we have in lecture of silicosis. Remember what we said about silicosis now? Mm-hmm. And there's another film I want to put up because it's got all three examples here. Remember we said that silicosis has 3 stages to it: early, intermediate, and advanced. Early, intermediate, advanced. There's the 3 stages. And the difference between this one and this one, remember we said, is number of nodules, how many they have. This is not normal, but it's a lot closer to normal than that one is. Mm-hmm. Look at the density change. Is that a bilateral, widespread, non-homogeneous increase in the lung density?
Yes.
Yep. Yeah. Bilateral, widespread, non-homogeneous is different than unilateral, localized, homogeneous, isn't it? Mm-hmm. Like a lobar pneumonia would give us, or a lobar atelectasis, where we get unilateral localized, or a tumor gives us unilateral localized. That's not even the same pattern of density change as this. Bilateral, widespread, non-homogeneous increase. That puts us in the middle of the chart, and that's interstitial disease classically. Interstitial. And then we only have 2 choices with interstitial. Remember, it's either nodules dots, or it's
Reticular.
linear branches, reticulation. You either got spider web lines or you got dots. Now, sometimes if you have a lot of little dots, because the beam's going through and going to add them all up as the beam goes through, sometimes it can make it look a little bit like, if you look closely at this, you can almost kind of start to look a little bit like some branching lines there, doesn't it? But if it's branching lines, it's got to be branching lines everywhere, not just in one little spot. You know, reticulonodular is not reticular here, nodular here. That's not the way it works. If it's reticulonodular, there's got to be reticular all over the whole lung, not just in one little spot. So this is nodular. Thousands of them, right? And then the size decision was 1 to 2, 3 to 5, 5 to 8, or big. Anything bigger than 8 millimeters is starting to get up into multiple centimeter size. Usually, of our 4 sizes, the first one and the last one are the easy to do. Are they little tiny or are they really big? The middle 2 are always the hardest because they can be very similar in size. So these are 1 to 2 millimeter nodules, aren't they? And there's probably thousands of them in there. This patient has the same thing, but much less numbers of nodules. And that's the only difference. Early and intermediate are still miliary. It's just you have a lot less nodules. So, I mean, it's a very subjective, there is no exact criteria. But, I mean, there's a very obvious difference. And then what happens to here? Yeah, remember they start clumping that we talked about? And look, even on here, it says, mid-zones lung and migrate toward the hilus, leaving behind overinflated emphysematous lung between the density here and out in the periphery. Remember we talked about the hilus being drawn up? Frequently associated with TB. Remember we said that?
Yep.
Yesterday, which is probably why there's retraction upward and inward, that this is likely an association, and that the conglomerate probably isn't going to happen unless the patient's had tuberculosis. We'll talk about this with TB. Post-primary or secondary TB is opportunistic. Remember we talked about that the pneumoconioses are somewhat immune suppressing? Which is why the autoimmune diseases tend to kind of flare up and occur more frequently in people that have pneumoconioses. And so what is it called if this patient then develops scleroderma? What was that one called? Silicosis and scleroderma. It's kind of a form of Kaplan's, but when it's silicosis and scleroderma, it's specifically called Erasmus syndrome. It's kind of a good way to remember it. Okay. Silicosis, scleroderma, Erasmus syndrome. E-R-A-S-M-U-S, I think is how it's spelled. Which was predominantly described in the UK, which is also where Kaplan's came from, was out of the UK. And yes, Erasmus is kind of a subtype of Kaplan syndrome, which is pneumoconiosis and autoimmune disease. Kaplan originally was described with black lung disease and rheumatoid. That was what Kaplan's was. So, I mean, Erasmus is really just a subtype of Kaplan syndrome. Okay? That's a really great example of early, intermediate, bad silicosis. Okay?
In the early stage, what would be the differential diagnosis?
This one, viral mycoplasmal pneumonia, TB, fungal infections.
Okay.
Those would be the main ones.
And how would you actually differentiate?
You can't.
Okay,
Yeah.
so
Just
kind of just keep an eye on
in a
it.
vacuum with this and no other history,
Mm-hmm.
it just becomes, this is a very faint miliary nodular interstitial pattern. Even this is a miliary nodular interstitial pattern. Without history,
You really don't
it
know.
becomes a differential, and that's all it is. Because I have no way of knowing without some history on this individual, what is this from? Does this patient have acute symptomatology or is it chronic? This patient's going to have chronic dyspnea.
Okay.
This likely years of time. and progressively worsening. But they gotta have the occupational history that supports an assumption of silicosis. They have to have worked around dirt, sand, dirt, gravel. They've gotta have worked around that somewhere.
Okay.
Yeah. If this patient's an office worker, they don't have silicosis
Yeah.
because you can't, there's no mechanism to get it.